further ado, Dr. Osmlek, thank you very much.
Yes, thanks, Dr. Lindau. Okay, so today is meant to be not just like me sitting here talking to you about airway stuff. It's meant to be like, this is common practical stuff that's useful. And it's not just like a bunch of random junk from like a textbook. So with that, if I can get the slides to move, I will. Maybe hope. Oh, okay, perfect. So the most important thing to start with is anatomy. I mean, it's the basics of everything we're talking about. And when I think of the head and the neck, there's a lot going on in a very small space. I always say there's a lot of high-end real estate in this one very narrow part of the body. That said, like if you boil it down to the basics, like the airway is very straightforward. Like don't worry about all the tiny little ligaments and this, that, and the other, or before you even divide it down. It's like you think about the airway, you either go in through your nose or your mouth, you make like one turn and you go straight down pretty much. Like, and that's the airway. And that's the principle you have to remember anytime you're dealing with the airway. It's like, I know where I need to go. I know how to get there. You don't have to make it super complex because we easily can do that. And especially when you start throwing in people who are vomiting or they're bleeding or there's a bunch of snot, the principle in the back of your mind is, I know where I'm going. I know how to get there. So the most upper part of that is like the nasal cavity. And most of us don't think about how big the nasal cavity is. It's like, oh, there's a little hole in the front of your face and like, you got to go straight back. Well, yes, truly, when you do nasal sprays, nasal trumpets, Dobhoffs, NGs, like you're just riding this floor of the nose. But there's all the turbinates and everything else up here that, you know, you can run into a lot of problems if you start going up. So the goal is always to remember, go straight back when you're in the nose. And that leads you back towards the nasopharynx. But otherwise, starting with entering in the airway, the mouth is the other common place, or the most common place, I would say, that we get into the airway with, you know, general intubations or things like that. But so when we divide the airway down into those more complex parts, you have your pharynx and your larynx, and they're pharynx, not pharynx, larynx, not larynx. I don't even know what the larynx is, but a lot of people throw that word out there, but there is a proper way to say it. But you divide the pharynx into three parts. So the back of the nose, nasopharynx, and then you go down into the oropharynx. That's the area where you have like your base of tongue, your tonsils, part of your soft palate. As you go a little bit further down, you're getting really close to the important stuff of the voice box, the hypopharynx. And really that's like those piriform sinuses on the sides of the voice box. You have your postcricoid area, which is back here, and then that posterior pharyngeal wall. And then you truly get into your larynx. And so when we talk about like a total laryngectomy, the part that we're removing is this area that's in orange. When somebody has a total laryngopharyngectomy, we're also including a good portion of this area in the purple. And so I just wanted to highlight some of the other important things when it comes to especially like our patients and why, you know, why things happen a certain way. But so let's go back to the oral cavity. So the palate is something that most people don't think a lot about, but it's got the two parts. There's the hard palate, which is truly a part of the oral cavity. And then there's that soft palate, which is part of the oropharynx. Like when it's intact, like you speak normally, you can pass something separately from the nose and into the mouth. But when we do maxillectomies or bigger procedures up there, like if you remove that tissue, there's this huge loss of air that resonates up into the nasal cavity. And that's like the big reason why people's voices will sound so different if they don't have, say, an obturator in there or a flap in there. And it's the fact that there's just this loss of control of that air. Usually this area here helps to keep that air going down this way as opposed to going through this entire space. And so that's one factor of it. The other thing, when we think about, you know, we'll talk about trachs and laryngectomies and all that stuff. But when it comes to airways where we're going to be worrying about putting in a trach, and especially like our post-op patients, maxillectomy patients aren't not necessarily them. It's because, you know, you can fill up all this tissue up here and block off the back of the nose, but in general, you're still keeping the wider portion of the airway open. And so you don't necessarily need to be worrying about putting an airway in safer down below because you don't have a bunch of swelling here. But when we're doing the pharynx stuff, the tongue, even parts of the jaw, like that's filling up this area of the back of the throat, and that's totally different. And so that's when we start worrying more about how are we protecting their airway? We know they're going to be swelling, so we have to be thinking ahead about those kinds of things. A few other important structures when it comes to the airway that people don't always think so much about is the jawbone and the hyoid bone. Like this little hyoid bone is extremely important. Like so many muscles attached to it, and it suspends the voice box. So like when we go and we do a laryngectomy, this little bone comes out, so does the epiglottis, all this stuff comes out, and then, you know, their airway's their airway. But if you're going and removing part of somebody's jawbone, like you have your digastric muscles that attach, a bunch of your tongue muscles attach, and when these guys are all released here, they sag. And when they sag down, but they also can sag backwards. And that's very commonly why some of these people will need tracheostomies. It's not necessarily that like us putting a fibula up there with some muscle, like it may fill a good portion of the airway, but sometimes it's the factor that things have fallen down too, plus they're going to swell. And that's why we need to put a more secure airway in there. So, you know, it's not just about what's going on right down here. It's very much commonly about what's going on with the bone up here, or even the little hyoid bone over here. And I think, oh, and the other thing I was going to mention, when anesthesia goes and intubates people, I feel like we hear them say, oh, they're very anterior. So what does that mean? Well, I mentioned that it's like a giant L shape when you go to intubate somebody. It's like you're going in the mouth, you're going straight down. Well, it's not a straight shot. Really, that's the esophagus. I mean, that's why it's what's their end tidal CO2. You want to know you're in the right place. So it is a little bit of a gentle curve. When somebody's airway is more anterior, it moves from like here to more over here. So it is more of a C-shaped curve. And so that's why they're more challenging to intubate sometimes, is because it's like you got to wrap around the curve, but then curve a little bit more. And it's not always the easiest thing in some people. And also usually what that means is they have sometimes a flatter or shorter neck. This person here has a very nice angle to their jaw and whatnot, so they'd be easier to intubate. But somebody who like has no space between here and here, that kind of changes where your airway is going to be sitting. So that's usually what that's referencing. So now just kind of focusing in on the actual voice box, the main part of the airway when we think of the airway. So it's all divided into 3 parts, and everything is just related to the level of the vocal cords. So you have your supraglottis, your glottis, and then your subglottis. So the vocal cord level is the glottis, anything up above there. So anything that's arising around your epiglottis, these are the arytenoids, the aryepiglottic folds, anything over here is supraglottic. That's very well vascularized tissue and also has a really good lymphatic system. So when we're talking about patients who are having, say, a laryngectomy for a supraglottic tumor, that usually means we're also going to be addressing lymph nodes in both sides of the neck, as opposed to just one side. When you move down into the glottic region, that's very much more commonly an area where things can be localized just to one side of the neck as opposed to the other. So from a surgical standpoint or caring for a patient post-operatively, there's a smaller volume of tissue that can often be removed with that. And then when it comes to the subglottis, so anything below the level of the vocal cords, so like the area where a cric would be done or the rest of your tracheal rings, really worry more about paratracheal disease. So you're not necessarily in those people worried so much about creating huge cavities in the sides of their neck next to the voice box level. And so then we'll jump into the different airway things. So the first is a tracheostomy, which is extremely common, not just for head and neck cancer patients, but it is, of the 2 procedures, it is the reversible one. Most of the times I think of it as a tool to help people get through whatever it is that they are dealing with. It's not necessarily something that is making them better. And I think that's a common misconception we have to talk to family members about, because they're told, oh, you know, grandpa's been on the ventilator for a while, we should move him to a trach. We'll help get him off the ventilator faster. It's like, well, I wouldn't say I'm promising you that I'm going to make him better that much faster, but it is a tool that will help him to become more comfortable and hopefully more mobile and all those kinds of things. And obviously with these people, we say the goal is still that at some point we will be able to remove this and he will be able to go back to breathing and talking the same way the rest of us do. And so I thought these pictures were kind of nice because it really shows you the level and the important structures of where we are putting a tracheostomy in. And so let's get the marker there. So up higher voice box level, your cords would usually be somewhere right about here. And usually this picture shows it, it's between the 2nd and 3rd tracheal rings. We will commonly place the tracheostomy tube. There's a lot of different types of tubes out there. The most common ones we start with are the ones with the balloons, because the people are usually on a ventilator and you want to maintain that circuit with the ventilator and not have a bunch of air escape around the tube, you know, back out their nose and their mouth. You just lose a lot of pressure that way. So when you're putting a tracheostomy in, you're putting in the one with the balloon. And then, everybody's airway is a different size. And so we commonly put in a similar size to start with, but there are a lot of different sizes of just the inner diameter, but also based on the thickness of a patient's neck, the length of the tube outside of the entrance or the tracheotomy versus the length actually going down within their airway. And then you'll have tubes that are like fenestrated. Those can more commonly be used. I haven't used a fenestrated tube in like years, like maybe in 7 years. So it's not very common, I feel, from our perspective, but sometimes people who will use the ventilator at nighttime, and they're breathing on their own more during the day. It's just a tube that allows more air to pass through it, but then also still be able to be used to use a ventilator at nighttime. Okay, so why are we performing tracheostomies? So there's a lot of different reasons, like I alluded to. So most commonly, just in the general population, I would say the things that we do are respiratory distress, or respiratory failure. So we did a ton of trachs with COVID, but like pneumonia, ARDS, those are common reasons why we get asked to place a tracheostomy, with the goal then that patient will eventually be able to be weaned from the ventilator and have that tracheostomy removed. But then there are people whose diaphragms are paralyzed. They're going to need to be on ventilators, and that's more of that not reversible situation. And that's the way that they can then breathe using the ventilator. But then also trauma patients and burn patients. And the thing about these people here too, is these are people who very commonly are going back and forth to an operating room multiple times. And that can create a lot of new trauma to the airway every time you go and re-intubate somebody. So like you can damage the structures, you can cause swelling of the structures. And then what you also have to think about is, okay, maybe that's an acute issue, but what happens long-term? A lot of those people can even develop subglottic stenosis. And that's a whole different bad problem to have as a result of, repeated intubations and trauma related to that. This kind of middle section here is where I feel those of us in head and neck get called in those, middle of the night, ER is calling. We're the airway people. If there's a problem, you're calling us. And so yes, head and neck cancer patients, especially those supraglottic tumor people where it's hanging off of the epiglottis or those aryepiglottic folds. Basically, you look down the back of their nose and you're like, well, I know what I should be looking at, but I can't see it. I have to look around something. And so those are the people who you're thinking about doing potentially an awake trach on. Same thing though with angioedema, and that can commonly be, let me go back here. So like that's very much the floor of the mouth and the tongue are just totally filling up this whole space here, and eventually then pushing posteriorly here to kind of totally block off that airway. So allergic reactions kind of fall into that same category, as do the dental abscesses. And then there's our weekly special, the post-op patient. We expect swelling. So if I'm doing a flap and I'm kind of trying to figure out, do I need to trach this person or not? So usually they have the breathing tube in already from the procedure. We've probably put down a feeding tube as well of some shape or form. And so what I'm usually doing is I'm gauging with like my hand, and that's just one of those things, we each do it a different way. But if I can get 2 to 3 fingers in the back of that person's mouth and pull their tongue forward and have my 3 fingers plus those other 2 tubes sitting there together, I'm pretty sure that this person's not going to have an issue with any respiratory, issues post-operatively if we just leave them breathing on their own. Somebody who I can like not get a finger back there, or it's like a stretch to try to put 2, those people you're like, well, there's going to be more swelling in the next like 3 to 4 days. Like maybe this is the type of person who you want to be putting a tracheostomy in. And then the other thing is too, not just like swelling from the fact that we're messing around with tissue up here, but it's the bulk of that tissue. And like we were talking about earlier, if you're putting something up in the maxilla, like you can pretty much block off the back of somebody's nose. And a lot of people are mouth breathers, they just don't realize it. And so they're going to be okay. But as soon as you start putting in a huge piece of tissue here that fills up most of the mouth, or it's kind of fills in the back of the throat here, those are the people who are saying, yeah, we need to do a trach. Or again, disconnecting everything from the front of the jaw here or along the hyoid, and those people where things are potentially going to be sinking down. Those are those free flap patients where we're thinking, we need to be thinking of something else. Okay, so kind of the mechanical parts of these things. There's a lot of different types of trachs out there. We tend to use the Shileys. I think this is the trach I've been most familiar with over the years. Cuffed is purely, is there a balloon or is there not a balloon? So the balloon is put in at the beginning. We usually wait about 3 to 5 days after we put in that cuffed one before we take out that or exchange it to a different tube. And that's basically just so that there's time for that tract to heal between the opening in the airway and the top of their skin. Because if you pull that too fast, like especially somebody who's in a short neck, laying weird position in the ICU, has like a central line in one side and all these other gadgets, like it's not an easy thing to, it's a bad situation potentially. So we wait those usually 3 to 5 days before we switch to the one basically where the balloon's not here. The introducer is really, really nice. The only difference between that and the intercannula really is the very little tip on it. It's much more rounded, and it's amazing the difference that little tip difference can make in introducing the trach into the airway, especially in a tight opening to start with. So we usually throw this little guy into this guy, introduce it into the airway, pull it out, and that's when your intercannula goes in. And then we're either suturing it or suturing it and tying it. Depends on the patient. If it's a respiratory failure patient, like the people we get consulted on from the Palm ICU, we are fine suturing it in, but putting those trach ties around it as well. With the free flap patients, we don't want to put the trach ties around. And I think, let me see, here's the picture. So when we're doing trachs, there's a few things that we run across right here. So we have these big blood vessels in the neck, and those are the vessels that we are hooking into some of their branches for free flap. And so if you start putting trach ties around somebody's neck right at this level, you're potentially, more importantly, compressing a vein. And so that's the reason why for our flap patients, we're not putting trach ties on them. We're securing everything with sutures. Some people's necks are just thick. So even if you try to put trach ties on loosely, it doesn't work. And so that's why we go crazy about those kinds of little things. But going back then to this picture is really nice too, because a lot of airway pictures, they just show you, oh, here's like your voice box area. Here's the cricothyroid membrane, which is up here. And then here's your first tracheal ring. Well, there's a lot of important stuff in front of it. Like if you feel on your own neck, like most of us can feel those tracheal rings, but you don't, the isthmus of the thyroid is usually like right across the area where you're going to be placing the trach. So when we're doing the procedure in the operating room, we're going through the skin, we're going through a little bit of fat, we're pushing the strap muscles to the side, and then we're coming across this part of the thyroid, and the thyroid is extremely vascular. I mean, if you look at this picture alone, Netter always did a good job of showing that, yeah, there's a bunch of little blood vessels here. Well, in some people, these anterior jugs come across the front here too, and so that's another vessel that you can easily get into. And so there's a lot of important stuff going on, the reasons why people can have bleeding from around their tracheostomy when it's first put in. It's not always, oh my God, they have that fistula with their innominate vessels. No, very commonly it's thyroid tissue, anterior jugular vein, but they can bleed a lot and they can make things very bloody very quickly. And so that's kind of important stuff when it comes to thinking about if you're trying to trach somebody or cric somebody at bedside, why is it not an ideal thing? The lighting's bad. You probably don't always have all the instruments you want. You're laying on this like low bed that is not perfect. And then you can get into bleeding like this and you don't always have the best suction. So we try to always avoid bad situations like that for a reason. But that's kind of a nice picture of the important anatomy when it comes to, the blood vessels we worry about and the important structures here. So one of the things when I get consulted for a trach on somebody as I go and see them, the one thing I really care about is like, one, have they had neck surgery before or not? Did they have a previous trach? Have they been radiated? That stuff. But like, if you can feel their airway, I mean, that's usually a good sign that things should be pretty straightforward. Somebody whose neck you feel and you're like, sometimes people do have huge goiters in the way and you don't find that out sometimes until you're in there because all they've had are like chest x-rays and things like that. So it's always those little things to pay attention to when you're doing these things. And then the other potential complication with putting in a trach is creating that false tract, or especially when you're exchanging it out between that first one that's put in say the OR and the one at bedside. Let me go back to this picture here real quick. Like in this person, they give a good example. There's a lot of soft tissue between the windpipe and the skin here. I mean, you can easily suddenly run this little guy down into the fat right in front of this plane, because when we're actually making the tracheotomy, like we're pushing tissue away and we're kind of creating a little space around it. So sometimes you could easily kind of keep opening up that plane that you were already opening to expose the rings of the trachea. So Another thing to keep in mind, just have good light, stretch out somebody's neck if you're changing out those tubes. And just remember, like, it's very, you know where you need to go. Like, you know where the skin is, you know where the windpipe is. It's just like an L-shaped curve. So, okay. And then the care of the trachs, which is very similar to care of laryngectomies, which we'll talk about next, but like suctioning things out. So when you put in a tracheostomy, you're changing the way the air is entering the body. You're bypassing. It's like plumbing. You're just going below the level of the vocal cords, but you're also skipping everything that your body is normally using to filter and warm or humidify that air before it hits your lungs. And so your lungs are not really happy when this cold, harsh air is coming in and hitting them. So what do? You create more sputum and gunk and all that stuff. So that's why suctioning is so important early on. It's because your lungs are trying to figure out, oh, wait, something's different about how the air is hitting me. And we do everything we can, we put on the humidification, we use the little saline bullets and stuff to help irrigate it out. But it takes some time just based on the change that has happened physiologically for your body to adapt to that. So that's why suctioning and irrigating are important. Cleaning the inner cannula, but also sometimes suctioning. If you take out that inner cannula, we'll go back to that picture, you take out this little guy, you have to clean that in the sink, but there's like this huge piece of tube here that you can collect gunk between this tube and that tube. So sometimes actually passing that really skinny like nasotracheal suction tube down there is also very helpful to help clean out that part of the tubing. Humidification, which we talked about, and also the ties and sutures. We use them in different situations, and very commonly it's very patient dependent. The reason why they're having a trach, are we worried about, occluding blood vessels for tissue we have hooked into that area? So questions about tracheostomies. I figure before we jump into laryngectomies, anything like from your guys' experience or anything like that? If not, that's okay. But I figure before jumping into Larry's, sometimes good to go over that. Okay, so the irreversible version, the laryngectomy. So this is a huge lifestyle change or modification for people. There's no going back. There's a lot more education that happens for our patients on speeches side. They come and they very much spend a lot of time educating the patients on how things are going to be different. It doesn't happen nearly, the level of education doesn't happen nearly as much with the tracheostomy in my experience. But this is something where I tell people, like, the goal is that you're going to get back to doing all the things you've pretty much been doing. Some of the things I tell them they can't do on the front are like swimming. Now, are there some snorkels and things that have been adapted for laryngectomies? Yes. How many people are actually going out and finding stuff like that? And that's, snorkeling is different than swimming laps. So as a swimmer, it's one of those things that you're probably not going to be swimming. Also, that means if you're a fisher, like if you're a fisherman, like you need to be cognizant of like the depth of the water that you are fishing in, because if you fall overboard, your airway is just a giant sieve where water is just going to go and just suddenly fill up your lungs. Like there's nothing like your glottis now protecting where you can hold your breath and prevent that from happening. And the other thing would be skydiving. Again, you can't like hold your breath and stuff. So I usually tell people those two things. For most people, they don't care so much about that. But again, there's a lot of social factors that are different too. There's a lot of, I think, misunderstandings or bad representations of laryngectomy patients. I don't think all the commercials that have been out there do a great job. They were like, are threatening people more. You're like, you better not smoke, you're going to end up like me. And you're like, oh my God, like what a bad way to portray that to everybody out there. I mean, it's just, that's not the right way to do it. So to go into what a laryngectomy does, and like, you guys will be amazed at the number of people in emergency rooms, anesthesia departments, just across medicine in general, where people have no real clue about what a laryngectomy means, like that there's like a big difference between that and having a trach. And so have there been scenarios where they cover the laryngectomy thinking, oh, we're losing air through this hole, cover it up and try to intubate through here? Well, you're suffocating the patient. Like, so if somebody, and most of these people will wear like the neck breather wristbands, like a medical alert band saying, hey, like I breathe through my neck, I'm a laryngectomy patient. And very commonly we tell our patients, you will need to educate the people who are taking care of you of what that means. And I mean, that's pretty scary if you're the one who's like in a bad situation and you're going to have to try to be teaching the people taking care of you what to do. So that's why learning this anatomical difference is so, so important. So this is like the picture I showed at the very beginning. So, here's floor of nose just above your maxilla. Here's your oral cavity, pharynx. Here's your voice box. And then again, we go and do a laryngectomy. We are removing this boxed out area that's the larynx. And so what happens when we make the cut here, this part of the trachea, which goes directly down to your lungs, is now going to come out at the surface of the skin here. And all it is a wide open pipe where, again, water can just fill right in. And so we have shower caps and things like that for people when they're taking a shower so that they're not like getting rained on and drowning because of that. But that's why swimming and things like that can be very risky, or falling into a body of water if you can't stand up to get yourself out of it are important. So we bring out the windpipe here, and that's usually one of the first things in the procedure that we're doing. And if, like, of all the procedures that we do, I would say a laryngectomy is one of the procedures with the most beautiful anatomy. I mean, I love neck dissections, like it's great anatomy, but it's not like laryngectomy where you truly see, you're seeing all the strap muscles, you're seeing the recurrent laryngeal nerves, you see the esophagus, you see the trachea, you see the base of the tongue, like you just see these things in such great detail. And it's one of the best operations to teach anatomy from. And so when we separate here and we lift the voice box out, this area right here, that part of the pharynx, in a person who has, say, a very well localized tumor within the voice box area, meaning it's not creeping up into the base of the tongue, creeping along the sidewall where we're really stealing a lot of the extra mucosa of the pharynx. There are some people where you can just close that lining on its own and not worry that as they heal that they will stricture down and have trouble eating. Because when we think about a laryngectomy, I think we think more about how the airway change or how people are going to be speaking and interacting socially is the bigger change. Eating is still, most people can go and eat what they want to eat, but eating itself also is different because it becomes more like a gullet. The way you close that lining, having removed a bunch of the muscles to help squeeze things down the pharynx and into the esophagus, it's a different way of eating, but we don't really focus so much on that. But the goal is that you want them to be able to eat. You don't want to cause them a problem where they're going to stricture down. So again, if they've never had radiation before, you're not planning on doing radiation for them. These are people who you can worry, basically not maybe need a flap, and then be able to close that lining. They will heal and they will be able to eat what they want to be eating. Many of our patients do not fall into that category. Many people have already undergone primary chemoradiation, or they've had a recurrence, or they have a very terrible tumor to start with that's, taking up a huge part of the voice box area, maybe even replacing it totally. And you have to really rebuild all this area. And in those people, you need to put a flap up there because you're at a lack of tissue. If you don't put something up there, one, you probably won't even close the pharynx defect, but two, if you try to and you make it as narrow as your pinky finger or a straw, like that tube's going to stricture down. Those people will have no quality of life as far as being able to eat and enjoy things the way they would like to. And so those are kind of the important things when it comes to what's different anatomically, the difference in just kind of the movement, but the structure of how the esophagus becomes, or the neopharynx, and then where the airway is sitting. And this right here is the area where, if you imagined, a little flap is sitting here, but that's kind of where that all goes. Okay, so again, I mentioned that the way we are communicating is the biggest difference when it comes to a laryngectomy. And there are lots of different ways that people can communicate after a laryngectomy. I would say we all have in our minds different ways of what we think is probably the best way for people to communicate. The most common thing I think most of us know about is the electrolarynx. I would say pretty much every laryngectomy patient across the country learns how to use an electrolarynx because it's a tool that is easy to make sure everybody can access. But then I would say most of our patients end up falling into this category as well. And the principle behind that is that people are placing the electrolarynx underneath the chin, and you're having tissue vibrate as air passes by to help generate the ability to speak. But then there are other tools. There's esophageal speech, which is literally people breathing in air into their esophagus, basically sucking in air and then burping air out to be able to transition it into intelligible speech. And then the other one is a TEP, which is not, I feel, it's not very commonly used here in my experience. Where I trained in Oklahoma, I would say 98% of patients who had a laryngectomy had a TEP placed. So the TEPs are nice. It's tracheal esophageal puncture. It's a little one-way valve, and I'm going to go to this next picture here in a second just to jump ahead. So this valve sits right between the trachea. So you can look in somebody's stoma and you'll see this little guy on the back wall, but it connects these two. And so the one-way valve opens so that air can only go from the windpipe into the esophagus. It will close when that air isn't forcing the valve open so that saliva doesn't leak back out down into the windpipe. And so somebody breathes in air, and I know these pictures kind of got cut off over here. This is one of those little HME caps, and this is somebody's thumb sitting here. But you breathe in the air, and then you occlude the opening of your laryngeal stoma, forcing then the air to go through that one-way valve up, and then there's vibration of this tissue that allows people to speak. These valves are really nice. They are not inexpensive. They're about $300 to $400 a pop. People will need them changed out at different rates. There are some people who can get by with a couple a year. There are other people who every 6 weeks need these changed out. And from a financial standpoint, that's not necessarily feasible. And so the difference is very much the biofilm that forms on that valve. If you're using your finger to occlude your stoma, you use your hands to do a lot of stuff. You go to the bathroom, not everybody's hand hygiene is the same. Like different bacteria will create biofilms at different rates. And that's why those valves have very different lives from one patient to the next. And so it's one of those things that normally you can change out in the office, but it can be very cost prohibitive. And so that's why I feel that not a lot of people get them. The other thing would be too, we are very aggressive here about putting in flaps to help rebuild these people who have, say, had previous radiation, are going to be heavily radiated. If we are putting in a huge piece of tissue here, we are often separating the distance between the wall of the esophagus and the wall of the trachea. And so this little valve is not very big. I mean, it's maybe a centimeter max. And so if you have like 1.5 inches of tissue sitting there, it's not going to work. So can you later go on and do a secondary TEP procedure? Yes. Do we do those sometimes? Yes, but I would say it's not the most common thing. And then the other thing is what we very commonly will see on the floor is you'll have like, this is that little standard kind of Larry tube that people will come to the floor with. It has the little slots where you can attach the ties. In most cases, if you want, we suture it in sometimes, but later on they can put the ties around there. These little guys, these are the HMEs, the heat and moisture exchangers that clip right in the front there. They help to make it easier for the patient to go out and about and not have to worry about carrying humidification. And especially the further out they get from surgery, like I mentioned with trachs, like their lungs are becoming familiar with the fact that cold, harsh air is hitting them, and you're not going to be creating as much mucus and junk that you were before. So the HMEs help with that filtration. And then if this picture right here, it kind of shows this little base plate here that the HME attaches to. This is kind of that ATOS base plate that you just put right around the stoma opening. And then you can clip one of these guys in the front, and you don't need to be wearing, say, this Larry tube later on. The Larry tube is nice, especially early on when people have a lot of swelling from surgery or tissue bulk. Like if they're laying in bed and they're kind of covering their airway, they might have trouble breathing. So it just is a little bit of a stent to help keep that area more patent while they are recovering. It's different than the trach tube. Also, if you question what the tube looks like, it's much more basic. It also has a wider opening at the front and narrower opening on the inside, whereas a trach, if we go back to those pictures from before, everything is very much similar in diameter from start to finish. And so that's another thing that to pay attention to. But when the terms, laryngeal stoma, or I should say trach versus stoma, they're thrown around a lot, and people don't always think about what they're saying. They're just interchanged very commonly. So you really have to pay attention to the person who's sitting in front of you, because if they have like a big opening here and they have a wristband on, they've had a laryngectomy, and don't try to do anything through their mouth. Like this is the airway, and that's the best thing that you can possibly do to help save their life. I mean, my husband's one of the colorectal guys, but when he was on the head and neck service as a resident, they were at the med center and there was code going on, and Dr. Dan came up to the code and he saw what they were doing. And all he did is he took the tube, he put it in the airway and he said, now you're going to ventilate better. And I mean, and it suddenly like blew everybody away, but it's just one of those things that like pay attention to where somebody's airway is. It's not always just a trach. Like especially in a high volume place like this, you got to know kind of what's going on. So that's kind of the most important stuff, I think, when it comes to the trachs, the Larry tubes. the airway things that we are doing. So will open up for questions about any of that stuff. If there's anything I didn't talk about that you want to ask questions about too, I'm game for it.
I wanted to add something.
Yeah.
Just on the floor,
Mhm.
I wanted to make it clear that when you're wearing an HME on your Larry tube,
Mhm.
you do not need humidification.
Yeah.
So oftentimes I'll see them with the HME on and a trig collar. So it's kind of one or the other.
Yeah, and I feel like we don't very commonly have people wearing the HMEs in the house as much as when they get out of the house. And we often have the humidification collars sitting there, but yeah, it's just kind of, the collar isn't going to be working well if you have the little filter sitting in front. So it's either one or the other, but that's a good point. Yeah.
It's a good thing you say that, Jill.
Mhm.
I'm a nurse, which was
Yeah. Perfect.
So we put the HME on,
Mhm.
and the nurses are saying that head and neck say it's okay to have the trig collar on with it.
No,
And I
I
try to
always pull it
explain
off.
to them that is incorrect.
Right.
And they still want to hang it there. It's like, you're not
No.
doing any good.
Right.
Turn that off.
Yes.
You only do that like at night when you
Mhm.
turn that HME off.
Right.
And they just, the concept.
Yeah. And I think it boils down to also when we're comfortable with putting an HME on, if somebody's coughing out a bunch of secretions or there's still some bloody stuff coming out, we're not putting that HME on because it doesn't allow that stuff to come out. And that's why, people will have this little tube. Oh, sorry, I shouldn't have left this page. We'll just have this opening. Oh my gosh, sorry. I think it's going to filter through these. This opening wide open so we can still suction out things. They can cough stuff out before we're putting this little guy on, because this is a nice little piece of filtration foam that not much is going to go through it other than air. So
if we can
That's
just
good.
get like
Yeah.
reinforcement from you
Yeah.
guys when you see that,
Mhm.
we've heard, oh, heaven, that's so
Yeah.
it's okay.
And that's
We're like,
why-
no, no,
Yeah.
it's not okay.
Right, and that's what I try to do, and that's why I wanted to bring it up, hoping that there's.
Yeah, no, that's good.
people on here, just because usually we don't put the HMEs on until they're starting to transition home. It's
yes.
definitely not those first few days
Yeah.
at all. But the first thing I talk to my patients about when we put those HMEs on is in the event that you feel like you are starting to struggle, first thing I want to do is pull that
Pop it off.
HME off.
Right.
Now, if they are just at nighttime, sure, if they're hanging out in their chair for a while, absolutely pop that HME off, put that trig collar on, just because that's extra humidification.
Yeah.
But I see it so much of using both, and I'm like, oh, this is silly, get that stuff off
Yeah.
their neck, use that HME. And so I
Yeah.
wanted to.
Yeah,
definitely
and a lot of it is introducing these concepts and the tools to the patients while they're in house, because the goal is to become very, very familiar with it. And it's the same thing, like in my mind, like whether they're a trach or a laryngectomy, a lot of them are like nervous about using this stuff. And it's like, you of all people have to be the most comfortable with it because this is your lifeline. This is your airway. If you start plugging things up with mucus, like you need to be able to take something off, suction it out, use a pickup, look in a mirror, grab stuff. So, I mean, I should say like when you have a trach, you can still aspirate. If you've had a laryngectomy, things can still fall down the front of your neck and end up causing you to aspirate. I mean, if you're sitting there with your grandkid and they drop an M&M, well, or that TEP that I was showing you about, these guys, they have fallen out and gone down into the main bronchus. So, I mean, stuff can go down any of these holes. So these people need to be able to look in the mirror, know what they can or can't do, and when they need to be able to go to like an ER or something like that. But I always like to make sure that that person plus whoever their immediate support people are, that they all understand like how to use the suction catheter. Like, some people will teach just down about 10 centimeters on that. I'm like, if you really need to, like, you can go past that. You're not going to hurt anything. It's just a giant, pipe going down into your lungs. And so don't be suctioning though the whole time you're going down and coming back. It's going to be hard to insert that catheter if you're suctioning on your way down. But then also like you're sucking all their air out. So like, don't take like 25 seconds to like slowly pull that little guy back. I mean, they're going to be like, I'm drowning, like, no air. So those are important little tools that I try to make sure that they all are very comfortable with before they leave the hospital. So.
And another question
Mhm.
is about Airway.
Mhm.
So there's like an up and down about what you guys think is okay for us to throw them on the Airway. Because some of them come out, most of them
Yeah.
are all so swollen.
Right.
You don't want to add that extra heat.
Right.
If they're so dry.
Right.
Their secretions are becoming plugs.
Yes.
So they need it.
Yes.
Just you guys
I-
have the okay for us just kind of throw them on?
Yeah, I think every single one of the providers is going to tell you something different. If I know my partners well, everybody has their own 2 cents about that. I would say,
What she said for the folks on the online.
so I'd say the use of the Airway in patients who are immediate post-op, they need that heat to help to break up all the junky stuff that is collecting. Some people are okay with it, some people are not, but it's too much maintenance to just be like suction irrigating otherwise for be it respiratory or nursing care. And so I think it's very much patient or provider dependent what they're going to say. I think if it can be, used cautiously, I think it's a very useful and good tool, and I would have no problems with it. But I think it's very much the patient and what was rebuilt or that stuff, and the person who was the reconstructive person. So, and that will vary from, hospital to hospital then too. But I think it's a very useful tool. So I'm going to give you a gray zone answer on that one, unfortunately.
Because we don't want to have to call every.
Well, right. I totally. And so that could be something that we can work to talk with Carissa and Jill about stuff like that, like, pass on to the residents and them that like this person, we're going to be okay. This person, let's hold off for a little bit or something. We can work on our communication better about that probably. Other questions?
When would a Jackson Pratt trade be appropriate or that he's not used the metal trades? We used to see people with those ones. And then sometimes people just having a stove up with nothing, no appliance at all.
Yeah, and I would say early on when people are healing or they're going through radiation, we like to have some type of little tube there just to help maintain patency so things don't stricture down. But I mean, I know so many people that like, especially where in Oklahoma or train where everybody had TEPs, like nobody had like Larry tubes on the regular. Like, I mean, they had their little TEP back there. They had that either potentially hands-free HME on the front sometimes so that they wouldn't need to use their hands. And I think that that's kind of the way it went. I've never used one of the metal ones. I feel I have had one patient who temporarily had a metal one with the metal trach by one of the laryngologists at the university. She had put that in as a temporary tube in the process of working to decannulate the patient. So I just don't think they're being used as commonly. Yeah. Other questions? But there's so many different types of trachs out there too. And so sometimes it's, what the person putting it in was most comfortable with, or the facility the patient came with, what's their supplies, I think and I think especially in the last couple of years where there's been this like up and down of what's available, we've been using a lot of different things we maybe haven't as commonly used. So I think that's part of it. Okay. Anybody online? Or are there any other chat questions? Okay, cool. Well, that's all I've got for you guys. I hope it makes some, like the common basic stuff makes some sense. I mean, that's the key really, is just knowing what is a laryngectomy versus a tracheostomy and what that ultimately means for that patient's airway. So cool. Thanks for coming.
Thank you so much.
Yeah, thank you.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.